How are you? My name is Michaela and I'm one of the local intensivists. I work at the Gold Coast University Hospital. I've been told I have to say that because you can't call it the Goldie anymore since it's so brand new. I also work at the Flynn, John Flynn, which is a cardiac centre just down near Tweed. Okay, who never intends in their entire rest of their life to ever sit a fellowship exam ever again? I'm going to put both hands up. Right. I did a lot of anaesthetics through my ED training, and I thought, wow, 18 months and another exam and I could be an anaesthetist. And my partner said, you can also be single. So I'll have to put both hands up. Who intends to sit a fellowship exam sometime in the future? Okay, so most of this stuff is for you, and you get a free pen. So what I'm going to do is I'm going to give you, those who never intend to sit fellowships exams again, they can make paper planes out of it. Those who tend to sit a fellowship exam can sleep with that under their pillow. What this is, and the way I study, is that you will have to know the difference between intermittent hemodialysis, slow or sustained low efficiency dialysis, and continuous renal replacement therapy, And I have to say that Yogesh and I have been sitting back in the corner and we've really tried not to have patronising smiles on our faces because we are the sled people and it is so much better than continuous renal replacement therapy, acronym crap. So I'm just quickly going to go through these things, a couple of clinical pearls because I'm already 3 minutes over. So where we don't have to go through all the bits and pieces about what it did because Celia did an excellent job of this. And so we're just going to go through a quick couple of clinical pearls because if you like to test yourself as I do, I have an empty thing on the front, which is the empty table, and I fill that out, and if I can, that's brilliant. And if I find that I can't, then the answer's on the back. And so that's the way I study, so I thought you might like it. If you're really keen on scribbling at the same time, I've got pens. Anyone want a pen? The reason why you should know the difference between the three of them is because they're all around the place. But the main reason is because if you know the tricks of all of them, then you can just manipulate the pumps to your satisfaction. And you can try and make a CRRT machine behave a little bit more like a sled, good luck with that. Or you can slow your sled up or down so that it can either become a CRRT or it can become an IHD. And that's the beauty of it. Because all it is whether the pumps go faster and slower. So this is what we're used to. This is our lovely little Thelma who comes in 3 times a week, has a bicky, cup of tea, chat, wanders away again. And so this, of course, is going to be your intermittent hemodialysis. This is going to be your continuous. And SLED, basically, if you think of it, is the love child of both of them. It has the best of both, and it doesn't have the genetics for either of the bad stuff. Now then, the membranes are the same. The membranes for the CRRT machines, they are really, really high flux. Flux means permeability. Because they are so slow. They are so crap that you need a really good flow backwards and forwards and wash because you just won't be able to get everything you need out of it. You won't be able to scoop the potassium off, take the lactate down, resolve the acidosis. And so you will have to have a high flux mechanism. However, if you are in intermittent, then it's all right to have a low flux because everything is going so fast. You've got litres going through per hour. You've got lots of blood going through. If anybody's ever had to deal with an emergency AV fistula disaster, you know how easy it is to bleed to death in a couple of seconds from an AV fistula. And so you can have a low flux system. Now, in the some people have high flux in their intermittent hemodialysis, and these are the people that come onto dialysis late with a albumin of less than 40. So this is the MPA study from the Europeans, mostly low flux, but the technology is getting a lot cheaper with them. Also low flux is that they're cellulose based, which sets off a huge inflammatory surge reaction, and you don't want that. Now, the filters should last at least 24 hours for continuous renal replacement therapy, a single session for the other two. So you don't have to stress as much about anticoagulation. Yogesh can do that. Now the blood flow rate, the two key things to all these ones and the ones that you're going to manipulate up and down, the key things are going to be the blood flow rate and the dialysate rate for both of them. The blood flow rate is fast, as you would know from an AV fistula in the IHDs. It can also be fast in the sleds, which means that you can use the native fistula when you use sled. You can just plug them straight on. You get the renal nurse down who's got, what is it, competency. She can plug it in, a couple of hours, out it comes, everybody's good. You don't have to give them another hole. Right. Whereas it is a slow drip if you're doing continuous renal replacement therapy. 30, 60, about 50, you're really starting to run out of steam here and clotting as soon as you look at it. Up to 150, sometimes the machine can creak and maybe do a 250 and then it starts to rock. But it's really slow in dripping. That is a Gothic vampire site. It's great. Anticoagulation strategies, completely different. If it's continuous, one shot fits all. Bit of Clexane, out the door. If it's continuous, heparin, citrate. SLED, either one shot or continuous, you can make your own mind up. The rate, the dialysis rate, that's what we're talking about. It's basically blood going the other way. So the dialysis rate, and let's have a bit of a look. See how this lovely thing here has got bags that you go on and off and on and on, and which is what Celia was talking about. If you're talking about a SLED machine, it looks exactly the same as your intermittent machine, and so everything is piped through the wall. So this is why you can get 35, 50 litres an hour, just like you can in the intermittent guys, whereas these guys, try getting a nurse to do 35 litre exchanges per hour and see how far you get. She won't like you. Okay. So lactate and bicarb we've just talked about. In your SLEDs, the bicarb is here at the point of care, but you guys in continuous will be using the lactate. There does seem to be a survival advantage to bicarb, and I can't now remember the paper. However, if you use the lactate, you just have to watch the lactate go up to 5 or 6. When do you guys start getting really nervy about the lactate? 7 or so. About 7 or so? I'd be really nervous by then, but you've got more experience than me. Exactly right, if the patient's tolerating it, but it's really a number that you just hate. And you go on to the additives for both. Session times, this is where it comes into its own. You can put it on overnight, and you can take them out for some pot plant therapy, give them a bit of sunshine, get them down to their CT, get them wherever they need to go, sit them up, sit them out of bed. Whereas with continuous, they're stuck. And if you have a dodgy access and they're not allowed to move, you're really stuck. Not only are you stuck, but half the time you're paralysed. And everyone just sort of stands there like this the entire time. Okay, that is a very quick run through so that I can give you, I guess, more time, because anticoagulation is pretty much the big cheese. But these are the 3 different modes and the 3 different ways you can use them. And now you know that there's no one set way to spin any of the pumps, just what the machine will allow you. Then you can start using whatever machine you've got and push it to the limit. So if you've got somebody that you really want to make the acidosis better really quickly, and one of the dodgy indications, which is never going to be on your absolute indications, is what you said, sir, cardiogenic shock, where hearts hate acid and they do not like it. If you want to get the acid back up or prevent it going back down, because you've got an ejection fraction of 20%, then you will run them against a high bicarb. You'll give them a bicarb shot, and you'll have to run the blood flow low, but you'll run the dialysate because they won't cope with it, but you'll have to run the dialysate really high and full of bicarb so that you can strip off as much as you can. And that's the way you can play with it. With SLED, that becomes a lot easier. I'm so trying not to be patronising, but come to my cardiac arrest one, where you've done much more cardiac surgery than the Flynn or the Gold Coast at the Royal North Shore, and patronise back. Any questions about what we're doing with the 3 different ones? I hope the table is helpful.
So you can't use citrate on SLED?
You can, and this is where you can definitely become more patronising. We don't have that yet down here. However, Nambor's worked it out. And so they have a 1-page protocol, and they read SLED and citrate. So they are the most advanced and have got the best of both worlds up at the Royal Nambor.
So is SLED universal in Queensland?
No. The big disadvantage of SLED, she says, having sung its praises, the big disadvantage is it needs a couple of million to start up, because you need to replumb the system, because you've got to plug it into the wall. So try telling the government who are going to be out on its ear in 18 months that you're going to save a lot of money over 10 years, and that can become very difficult for your administration system to fathom.
So you know it's called sustained low efficiency, but it's
Yes.
low efficiency compared to intermittent hemodialysis.
Correct,
So
and
match
that's the
that
key.
basically
That's the
It's
key.
even less efficient. Call it
Very much.
least efficient.
Yeah, so the C stands for crap. Yeah, so I really couldn't understand this when I came down because I'd never met it before. I'd only heard about it in the abstract in textbooks. And why do they call it slow or why do they call it that? It's slow compared to intermittent. So intermittent is the Ferrari, sled is the family sedan, and continuous is the 1975 Mini Moke. It'll get you there, but half of it will be on the road behind you. Any questions? I like that question. Thank you very much.